Psychology paper number 15, Clinical Psychology. 1. Learning outcomes. After studying this module, you will be able to know and understand the concept of attention deficit hyperactivity disorder, identify the clinical picture and causal factors of ADHD, evaluate the various methods of treatment. 2. Introduction. Attention deficit hyperactivity disorder is often referred to as hyperactivity, is characterized by difficulties that interfere with effective task-oriented behavior in children, particularly impulsivity, excessive or exaggerated motor activity such as aimless or haphazard running or fidgeting, and difficulties in sustaining attention. Broder and Pond, 2001. When such problems are critical and tenacious enough, the criteria for diagnosis of attention deficit of these children are met. The primary characteristics of such people include a pattern of inattention such as not paying attention to school or work-related tasks. These deficits significantly disrupt academic efforts, as well as social relationship. 3. Clinical description, prevalence of ADHD. What distinguish the hyperactive behavior from an identifiable disorder? The diagnosis of ADHD will be appropriate when these behaviors show up for a particular time period, insistent across different situations, and are linked to significant impairment in functioning. NIH Consensus Statement, 1998. ADHD children have great deal of difficulty sustaining their attention on a task or activity. Barkley, 2006. Their tasks are often unfinished and they often seem not to be listening when someone else is speaking. In addition to this, Psychology paper number 15, Clinical Psychology. Serious disruption in attention. Some children with ADHD display motor hyperactivity. They are unable to sit at one place in a school for more than a minute. Their restlessness in a school is a considerable source of concern for their teacher and peers. In addition to hyperactivity and problem sustaining attention, impulsivity, acting apparently without thinking, is a common complaint made about them. DSM-1-BTR differentiate 3 types of symptoms. The first includes problem of inattention. They appear not to listen to others, they may lose necessary school assignments, books, and they may not pay enough attention to details. They make careless mistakes. The second type of symptoms includes hyperactivity, which includes fidgeting, having trouble sitting for any length of time, always being on the go. The third general symptom is impulsivity, which includes blurting out answers before questions have been completed and having trouble waiting turns. Either the first or second and third, hyperactivity and impulsivity, domains of symptoms must be present for someone to diagnose with ADHD. Inattention, hyperactivity, and impulsivity often cause other problems that appear secondary to ADHD. Academic performance tends to suffer, especially the child progresses in school. The cause of this performance is not known. It could be a result of the problem with attention and impulsivity characteristic of ADHD, and in some children this can be made worse by factors such as concurrent learning disability, which are common in boys with ADHD. ADHD children are rated to be unpopular and rejected by peers. Evidence suggests that some children with ADHD actually have an inflated sense of their own competence in areas such as social acceptance, physical appearance, and self-worth. Anxiety and depression, the internalizing disorders, occur simultaneously with ADHD. Recent estimates suggest that as many as 30% of children with ADHD may have comorbid internalizing disorders. Approximately 15 to 30% of children suffering from ADHD face difficulty in math, reading, or spelling. Barkley, DuPaul, and McMurray, 1990. Because of this difficulty of adjusting to a typical classroom, they are placed in special educational programs. Barkley et al., 1990. Although having both ADHD and conduct disorder is associated with substance use and abuse, a prospective study found that the hyperactive symptoms of ADHD predicted subsequent substance, nicotine, alcohol, illicit drugs use at the age 14, and abuse or dependence at age 18 even after controlling for symptoms. Conduct disorder, and this was equally true for boys and girls. The consensus on prevalence estimates of ADHD is that 3 to 7% of school children worldwide currently have ADHD, or used across countries as diverse as the US, Kenya, and China. However, one study reported a much higher prevalence rate of 16.1% for ADHD. Woolrich, Hannah, et al., 1998. The disorder occurs most frequently among pre-adolescent boys. It is 6 to 9 times more prevalent among boys than among girls. ADHD occurs with the greatest frequency before age 8 and tends to become less frequent and to involve briefer episodes thereafter. ADHD has also been found to be comorbid with other disorders such as oppositional defiant disorder. Drobic, Gatto, et al., 2004. Some residual effects, such as attention difficulties, may persist into adolescence or adulthood. Odell, Warren, et al., 199. In India, the prevalence of ADHD among primary school children was found to be 11.32%. Prevalence was found to be higher among the males, 66.7%, as compared to that of females, 33.3%. The prevalence among lower socioeconomic group was found to be 16.33%, and that among middle socioeconomic group was 6.84%. The prevalence was highest in the age group 9 and 10 years. Psychology paper number 15, Clinical Psychology. 3.1 DSM-1-BTR criteria for attention deficit hyperactivity disorder. 3. Causal factors in attention deficit hyperactivity disorder. It still remains unclear to what extent the disorder results from environmental or biological factors, and recent research points to both genetic and environmental precursors. Heckman, 1996. Many researchers believe that biological factors such as genetic inheritance will turn out to be important precursors to the development of ADHD. Durson, 2003. But firm conclusions regarding any biological basis for ADHD still awaits further research. 4.1 Genetic factors. Substantial evidence indicates that a genetic predisposition towards ADHD plays a role. Thapar et al., 2007, and numerous large-scale studies indicate a genetic component to ADHD, with heritability estimates as high as 70 to 80%. Most attention to date focuses on genes associated with the neurochemical dopamine, although norepinephrine, serotonin, and gamma-aminobutyric acid are also implicated in the cause of ADHD. There is a strong evidence that ADHD is associated with D4 receptor gene, the dopamine transporter gene DAT1, and the dopamine D5 receptor gene. DAT1 is of particular interest because Ritalin is one of the most common treatments for ADHD. Inhibit this gene and increase the amount of dopamine available. Even with these promising findings, most investigators agree that a single gene will not ultimately account for ADHD. Rather, several genes interacting with environmental factors will provide the most complex picture of the cause of ADHD. Additional gene-environment interaction studies are underway, and if these findings replicated, we have a clearer picture of how genes and environment interact in ADHD. Psychology paper number 15, Clinical Psychology. 4.2 Neurobiological factor. In children with and without ADHD, brain structure and function differ, particularly in areas of the brain linked to the neurotransmitter dopamine. For example, studies of brain structure have found that dopaminergic area of the brain such as caudate nucleus, frontal lobes, are smaller in children with ADHD than without ADHD. Castellanos et al. 2002, Swanson et al. 2007 studies of brain function have found that children with ADHD exhibit less trigger in frontal areas of the brain while performing different tasks. Casey and Durston, 2006, Nig and Casey 2005. In neuropsychological tests, children with ADHD perform poorly, and these tests rely on the frontal lobe, providing further evidence for the theory that a basic deficit in this part of the brain may be related to this disorder. 4.3 Prenatal and perinatal factors. Psychology paper number 15, Clinical Psychology. Prenatal and perinatal complications or other neurobiological factors for ADHD. Low birth weight, for example, is a quite specific predictor of the development of ADHD. Breslau et al. 1996, Whitaker et al. 1997. Mother's use of substance such as alcohol and tobacco are related with other complications or prognostic of ADHD symptoms. 4.4 Environmental toxins. In 1970s, environmental factors played a major important role in the development of hyperactivity. Feingold proposed that additives and artificial colors in foods disturb the central nervous system of the children who were hyperactive, and he prescribed a diet which does not involve them. However, well-controlled studies of the so-called Feingold diet have found very few children with ADHD respond positively to it. Goyette and Connors, 1977. Even though these early findings did not support Feingold theory, researchers continue to examine how different elements of the diet, particularly additives, may influence hyperactive behavior. A recent study found a similarly small effect of food additives and artificial coloring on hyperactive behavior. Research didn't support the popular view that refined sugar causes ADHD. Woolrich, Wilson and White, 1995. Research suggests that small degree of symptoms of hyperactivity and attentional problems are may be associated with lead poisoning. Researchers continue to whether lead exposure might play a role, however a small, in the etiology of ADHD. Nig, 2006. Nicotine specifically, maternal smoke and an environmental toxin that play a role, however small, in the etiology of ADHD. Several animal studies indicate that chronic exposure to nicotine is associated with decreases in dopamine release in the brain and causes hyperactivity. Dopaminergic system of fetus is affected by maternal smoking as shown by research, which results in behavioral disinhibition and ADHD. 4.5 Psychological factors in ADHD. In the etiology of ADHD, research results show that neurologic and psychological factors play more important role as compared to psychological factors. Relationship between parents and child interact with these neurobiological factors in a complex way which contribute to ADHD. For example, parents of children with ADHD may give them more commands and have negative interactions with them. Anderson, Hinshaw, 1994. It results in more negative interactions between. Certainly it becomes difficult for parents to bring up a child who is impetuous, hostile, non-complaint and unable in following the instructions. Hyperactivity and increased compliance in children can be reduced with the help of stimulant medication. Significantly when such medication is used, either alone or in combination with behavioral treatment. It is also very important to note parents' own history. Genetic component plays a major role in ADHD. That's why children of ADHD parents have a higher probability of acquiring the disorder. 5. Treatment of ADHD. Although hyperactivity syndrome was described to be 100 years old, disagreement over the most effective methods of treatment continues, especially regarding the most effective method of treatment like use of drugs to calm down a hyperactive child. 5.1 Stimulant medications. The first class of medication used for children with ADHD is the stimulants. Stimulant medications, such as methylphenidate, or Ritalin, have been prescribed for ADHD since the early 1960s. Other medicines approved by the FDA to treat ADHD include Adderall, Concerta, and Strattera. In 2006, an estimated 2.5 million children in the United States were taking stimulant medication. National Survey on Children's Health 2003, including almost 10% of all 10-year boys. These drugs have proved helpful for more than 70% of cases in at least temporarily reducing hyperactivity and impulsivity and improving concentration on tasks. Connor, 2006. Adderall, which is a longer-acting version of these psychostimulants, reduces the Psychology paper number 15, Clinical Psychology. Need for multiple doses for children during the day but has similar positive effects. Connor, 2006. Originally it seemed contrary to expect that children would calm down after taking a stimulant. However, on the same low doses, children and adults with or without ADHD react in the same way. It appears that stimulant medication reinforce the brain's ability to focus attention during problem-solving tasks. Connor, 2006. Although the use of stimulant medications remain controversial, especially for children, most clinicians recommend them temporarily, in combination with psychosocial interventions to help improve children's social and academic skills. Research suggests that other drugs, such as one of the antidepressants bupropion, imipramine, and a drug used for treating high blood pressure, clonidine, may have similar effects on people with ADHD. Spencer, 2006. Not all children with ADHD have depression or high blood pressure, although depression can be a problem in a portion of these children, but these drugs work on the same neurotransmitter systems, norepinephrine and dopamine, involved in ADHD. All these drugs seem to improve compliance and decrease negative behaviors in many children, and their effects do not usually last when the drugs are discontinued. 5.2 Psychological treatment. Some portion of the children with ADHD do not respond to medication, and most children who do respond show improvement in ability to focus their attention but do not show gains in the important areas of academic and social skills. Smith, Barkley and Shapiro, 2006. In addition, the medication often result in unpleasant side effects, such as insomnia, drowsiness, or irritability. Connor, 2006. Because of these findings, researchers have applied various behavioral interventions to help these children at school and in home. Reinforcement programs reward the child for improvements and, at times, punish misbehavior with loss of rewards. Other programs incorporate parent training to teach families how to respond constructively to their child's behavior and how to structure the child's day to help prevent difficulties. Sanuga, Bark, Daly, Thompson, Laver, Bradbury and Week, 2001. Social skills training for these children, which includes teaching them how to interact appropriately with their peers, also seems to be an important treatment component. For adults with ADHD, cognitive behavioral interventions for the distractibility and organizational skills problems appears quite helpful. Most clinicians typically recommend a combination of approaches designed to individualize treatments for those with ADHD, targeting both short-term management issues, decreasing hyperactivity and impulsivity, and long-term concerns, preventing and reversing academic decline and improving social skills. Training teachers so as to understand the needs of these children and to apply operant techniques are the considered school interventions. Welsh et al. 1997. In Academic Skills, Giving Peer Tutoring, DuPaul and Henningsen, 1993, and Giving Reports Daily to Parents about the Behavior of the Child, which are then rewarded at home. Certain classroom structures can help children with ADHD as shown in research. Varying the format and materials used in presentation for tasks, giving concise assignments and providing immediate feedback that whether it was done correctly or not, having an eager work-oriented style, giving breaks for physical exercise, computer-assisted drill programs are used in planning academic work during early hours of the day. Such environmental changes are designed to accommodate the limitations imposed by this disorder rather than to change the disorder itself. Some controversy surround the interpretation of these findings, specifically whether or not the combination of behavioral and medical treatments is superior to medication alone. Biederman, Spencer, Wylans and Green, 2001. One of the concerns surrounding the study was that although medication continued to be dispensed, the behavioral treatment was faded over time, which may account for the observed differences. Practically, if there is no difference between these two treatments, most parents and therapists would opt for simply providing medication for these children. Behavioral interventions have the added benefit of improving aspects of the child and family that are not directly affected by medication. Despite these advances, however, children with ADHD continue to pose a considerable challenge to their families and to the educational system. Psychology paper number 15, Clinical Psychology. Summary. ADHD is one of the more common behavior problem of childhood. In this disorder, the child shows impulsive, overactive behavior that interferes with his ability to accomplish tasks. This disorder is common in boys than girls. In ADHD, genetic factors play a major role. Neurotransmitter dopamine plays an important role in ADHD, and also areas of brain are involved. Genetic vulnerability suggests that family and peer variables play a major role in etiology of the disorder. Medication such as Ritalin and behavior therapy in combination is the most effective treatment for ADHD. Behavior therapy, cognitive behavioral methods had shown a great deal of promise in modifying the behavior of hyperactive. More longitudinal research is clearly needed before we can conclude that children with ADHD go on to develop similar or other problem in adulthood. Estimates of the number of children with ADHD in adulthood are likely to vary considerably. Psychology paper number 15, Clinical Psychology. 1. Learning outcomes. After studying this module, you shall be able to: what are types of anxieties? Learn about the various anxiety disorders. Identify the causes of these disorders, know about their treatment. 2. Introduction. Anxiety is an uncomfortable and highly unbearable condition wherein the person suffering feels uneasy. Anxiety can be triggered by a particular situation, person, object, or thought. This feeling of uneasiness can be experienced by people of any age, adult or child. For example, a child may feel anxious before writing his examination. Similarly, an adult might feel anxious when he is about to give a presentation. Anxiety to some people must be like an emotion that is regular or harmless. But there are some people who think of it as threatening and dangerous. Anxiety. The term can be used in two varying ways as mentioned by Spielberger et al., 1970. One way of using the term anxiety is to describe a person's relatively enduring characteristic. This characteristic may remain fixed or constant in any and every situation, may it be a happy or a disturbing situation. This type of anxiety which remains constant throughout is called the trait anxiety. Another way in which the term anxiety is used is in specific situations. A person may only experience anxiety when he or she comes across a particular specific situation. A person may only experience anxiety when he or she comes across a particular specific situation. This type of anxiety is called the state anxiety. These two types of anxieties help us distinguish between the various anxiety disorders that are diagnosed. Some disorders show trait whereas some disorders reflect state anxiety. The major adulthood anxiety disorders are: generalized anxiety disorder, obsessive compulsive disorder, phobia specific phobias and social phobias, panic disorder. Psychology paper number 15, Clinical Psychology. 2. Generalized anxiety disorder. Generalized anxiety disorder, as the name suggests, is the most basic and general form of anxiety disorders. The main focus of this disorder is upon the concept of worry. It presents the highest degree of trait anxiety as mentioned above. This means that the person suffering from generalized anxiety disorder is suffering from a very high degree of anxiety which is not specifically related to any situation or object or person. The person worries throughout the day without any threatening stimulus being present. This type of anxiety is also known as the free-floating anxiety. It is difficult to diagnose this disorder, but it can easily be differentiated from a phobia once it is diagnosed. Phobia is a fear of a specific situation, object or person, whereas generalized anxiety disorder lacks a specific stimulus. DSM-IV provides a criteria which helps in diagnosing GAD. The criteria states that the patient must report extreme worry over several of activities. The patient must also report that this worry has been present for not less than 6 months and for the most days in these 6 months. There is also a list of symptoms that has been listed by DSM-IV, out of which the patient must report at least 3 symptoms. Controlling the worry is difficult. The worry and anxiety is related to 3 or more of the following. 1. Feeling of being on the edge and restlessness. 2. Getting tired fast. 3. Low concentration level or blank mind. 4. Mood mostly being irritated. 5. Disturbed sleep. 6. Muscle tension, distress and impairment being caused in daily life due to the worry and anxiety. Epidemiology for generalized anxiety disorder is as follows. Generalized anxiety disorder, if compared with other anxiety disorders, is more commonly found in women than men. Studies have been conducted and it has been found that the onset of this disorder is generally early 20s or the mid-teens. The patients suffering from generalized anxiety disorder describe the onset of this disorder as gradual and insidious. Finally, studies also show that the prevalence of GAD is 3% in a time span of 12 months and a prevalence of 5% in a whole lifetime. Psychology paper number 15, Clinical Psychology. The etiology of generalized anxiety disorder provides explanation with the help of various perspectives. Psychoanalytic factors. According to Freud, there were 2 main reasons for a person to be diagnosed with this disorder. One cause was overprotective parents and the other was excessive punishment. If a child is punished for the smallest mistake and is forced to suppress his impulses, he will develop a feeling of fear and anxiety. This anxiety keeps building up until the child has grown into an adult, and this anxiety comes out as free-floating or trait anxiety. Also, when the child has overprotective parents who protect the child from the smallest threat, he is unable to develop any defense mechanisms. Thus, after growing up when he faces the smallest threat or fear, it leads to very high levels of anxiety. Cognitive behavioral factors. It is believed that people with anxiety disorders have a tendency to focus their attention more towards the negative or threatful information rather than positive information. This leads to a feeling of fear and anxiety throughout the day. Humanistic explanation. Humanists suggested that people suffer from GAD because they are unable to accept themselves for who they are. This happens due to extremely strict parenting, which leads to criticism and punishment. As a result, the child grows up to think that he is worth nothing and with low self-confidence and low self-esteem, which causes anxiety in the person when he faces even a slightly threatful situation. Sociocultural factors. It is believed that the socioeconomic status of an individual may affect him on a mental level. It has been seen that people belonging to the ethnic minority groups or the lower socioeconomic groups are the ones under extreme pressure of the society. Thus, these people experience high levels of GAD. Child sexual abuse in women also has led to high levels of GAD. Genetic factors. A meta-analysis study done by Hedma et al. 2018 showed that the coefficient of heritability in cases with GAD is about 0.32. This means that the possibility of genetically acquiring GAD is only 0.32 coefficients. Also, studies have shown that there is very low concordance rate between twin pairs. And no difference in concordance rate was found between dizygotic and monozygotic twins. Biological factors. Overactivation of the system of the brain which involves the PAPA circuit and the septohippocampal system are responsible for high levels of anxiety. This system is also called the behavioral inhibition system, BIS, as mentioned by Gray in 1983. GABA receptors also play a role. These receptors are responsible for controlling the activity taking place within the hypothalamus and sympathetic nervous system. Treatment. Cognitive behavioral treatment. Treatment for GAD involves the exposing the patient to the stimulus he fears and then applying various techniques by which he. Psychology paper number 15, Clinical Psychology. May prevent the response to such feared stimuli. There are 3 main key techniques which have been found to be effective in treatment of GAD. These techniques are relaxation training, worry exposure assignments and cognitive restructuring of anxiety-provoking thoughts. Psychoanalytic therapy. The aim of this type of therapy is to explore the subject's problems by understanding the patient's relationship with people around him, development throughout their childhood and by also noting the use of resistance and transference during the sessions. Pharmacological therapy. Benzodiazepines is one medicine that has been used for the cases of GAD and has been found effective to some extent. But benzodiazepines has several limitations if used for a long term. 3. Obsessive-compulsive disorder. The obsessive-compulsive disorder is considered to be one of the most severe and chronic of the anxiety disorders as stated by American Psychiatric Association APA. This disorder consists of obsessions and compulsions. Obsessions are repeatedly occurring intrusive thoughts or visual images with an urge that is difficult to control. Obsessions are of different types including feeling of contamination, fear of acquiring a disease in case of contact with others, tidiness or orderliness, bodily concerns, etc. Obsessions arise because the patient is unable to realize the fact that the suppressed thoughts and images are increasing the strength of these obsessions. Compulsions, on the other hand, are repetitive behaviors, overt or covert, which are purposefully done to reduce or completely get rid of the anxiety which arises due to the repeatedly occurring thoughts or images known as obsessions. Compulsions are performed in a ritualistic manner, with a particular procedure and number of times that they must be repeated. The most commonly seen and reported compulsions include hand washing, cleaning, tidying or orderliness, counting, checking of locks, etc. Epidemiology for obsessive-compulsive disorder is as follows. Obsessive-compulsive disorder is slightly more commonly found in women than in men. The onset of OCD is found to lie between late adolescence and early adulthood. Another important point is that this disorder is that the age of onset is earlier in men than women. The course of OCD is chronic. The etiology of obsessive-compulsive disorder provides explanation with the help of various perspectives. Psychoanalytic factors. The founder of psychoanalysis, Freud, said that obsessive thoughts are a result of the suppressed impulses and the compulsions arise as a psychology paper number 15, clinical psychology. Result of the ego defenses. Freud also believed that obsessions might arise due to the child being fixated on the anal stage. When the parents apply strict and rigid rules over the child's toilet training, the child tends to develop a rigid and obsessive personality while growing up. Behavioral factors. Just like GAD, behaviorists believe that OCD can result from a fear of a stimulus which is acquired by classical conditioning, and the fear is maintained by operant conditioning. Cognitive factors. Cognitive psychologists believe that the obsessive thoughts are intrusive and the person fears that he might hurt someone, thus the anxiety builds up. To reduce this anxiety, compulsions arise in the form of overt or covert behaviors. Genetic factors. Genetic studies have been providing mixed responses. That is, some researchers say that people suffering from OCD might have some genetic evidence, but some might not. Biological factors. Biologists have found out two causes that may result on OCD. The first brain system is the loop connecting the orbitofrontal area to the thalamic region. And the second brain system is the loop that connects the orbitofrontal region to the thalamic region, but via the corpus striatus. Treatment. Behavioral intervention. Like phobias, the patients are exposed to the feared stimulus and then they are helped how to prevent the reaction of the feared stimulus. This procedure helps the patient to see that there is no association between the stimulus and the patient's reactions. Relaxation is also used in order to help reduce anxiety and avoid the compulsions from happening. Cognitive behavioral treatment. Mind experiments, behavioral hypothesis testing, challenging inappropriate thoughts, thought stopping. These are some of the techniques that are used for treatment using cognitive behavioral interventions. Pharmacological intervention. Clomipramine and SSRIs are effective drugs that help in treatment of OCD, but have several side effects also. Surgical approaches. Surgery in people with OCD is only done when it is at the severe level and the person has not been responding to the treatment of any sort. It is not very clear how exactly surgery affects OCD patients. But it has been hypothesized that it severs the connections between the orbitofrontal and thalamic areas, which dampens down the activity within this circuit and hence the obsessive-compulsive disorder symptoms. 4. Phobias. Phobias are fears that are irrational and persistence of certain objects, situations, or animals. Phobias can be of two types: specific phobias and social phobias. Psychology paper number 15, clinical psychology. 4.1 Specific phobias. These phobias are irrational and persistent fears of specific or particular objects and animals. DSM-IV presents a number of features of the specific phobias. Fear in specific phobia is directed or indicated towards a specific object. When the person comes across these specific objects or situations, they experience intense fear and anxiety followed by avoidance of that object. The fear and anxiety rise to such a level that they interfere with the patient's daily functioning. DSM-IV tries to categorize between 4 types of commonly seen specific phobias: animal type lizards, snake, spiders, etc., natural environment type, dark places and heights, blood injection injury type, dentists, and situational type, elevators or closed places. Epidemiology of specific phobias is as follows. Phobias are one of the most commonly found mental disorders. It was found that situational type phobias were more commonly seen than animal type blood injection injury phobias. Specific phobias are more commonly diagnosed and acquired in women than men. Usually phobias start to set in at childhood. Etiology. Behavioral factors. Behaviorists believe that a person acquires a specific phobia when he has experienced a traumatic accident or incident. There are 3 basic principles of behaviorism which can explain the fear of a person from specific objects. These 3 principles are operant conditioning principle, vicarious conditioning principle, and respondent conditioning principle. Evolutionary factors. Ever since we have been evolving, we have learned from our ancestors that some objects or animals are to be feared of or to be stayed away from. For example, spiders or snakes, etc. Biological factors. There is a great possibility of heritability of specific phobias. Genetic bases also play an important role here. Researchers have proved that there is a greater concordance rate within monozygotic twins than the dizygotic twins. A diathesis stress viewpoint. This model states that specific phobias are acquired due to high exposure to psychosocial factors such as direct or indirect conditioning and biologically influenced propensity to experience fear and anxiety. 4.2 Social phobias, social anxiety disorder. We all experience some sort of social fears in our day-to-day lives, such as meeting new people or presenting in front of our superiors, etc. But people who suffer from social phobias are on a completely extreme side. People with social phobias have persistent and extreme fear of multiple types of situations. Social phobia was never considered to be a psychology paper number 15, clinical psychology. Psychological problem for many years. But in 1994 an alternate term, social anxiety disorder, was given to this problem, which was given by DSM-IV. Clinically, a person suffering from a social phobia is one who experiences fear and anxiety in going to new places, meeting new people and being in new situations altogether. The person feels that he might do some inappropriate behavior and he might embarrass or humiliate the other people around him and sometimes himself. Therefore, the patient avoids going to social gatherings or to new places and meeting new people. When a person suffering from social phobias is exposed to situations he fears, he experiences some physical symptoms such as blushing, fastening of heartbeat, drying of mouth, sweating, etc. Epidemiology of social phobias is as follows. Social phobias are commonly seen to begin in the late adolescence, that is from the age of 13 to 20 years. Its course is found to be chronic and unremitting. Most studies show that social phobias are more commonly diagnosed in women, but some studies say that there is an equal distribution across both genders. Etiology. Biological factors. Family studies show that there are higher possibilities of acquiring social phobias if a relative already has it. This prevalence rate is highest for social phobias. Behavioral factors. Conditioning plays a vital role in the development of this disorder. Public speaking and blushing in public strengthens the effect. Socially phobic individuals differ from healthy people because when excursuses are done in order to reduce fear and talk in front of people, healthy people take it in a positive manner, whereas for socially phobic people it goes into a complete negative and opposite direction. Cognitive factors. People with social phobias have certain negative beliefs such as, whenever I talk, I sound stupid, or, I hope I don't stare too much at anybody. These people always feel and believe that they will say something wrong. This leads them to feel anxious and fearful. Also, socially phobic people tend to selectively pay attention to threatful or negative situations. Treatment. Behavioral treatment. Systematic desensitization is the first very commonly used technique. In this technique, the person is exposed to the stimulus he fears in a systematic or hierarchical manner, and is then taught how to reduce the anxiety. On the other hand, flooding is another technique which uses the same procedure, but the exposure of the feared stimulus in this technique is sudden and at once. Pharmacological treatments. Many researchers have suggested that in case of phobias, medication is hardly required or even used. Thus, behavioral treatment is. Psychology paper number 15, Clinical Psychology. The best treatment data should and can be provided to people suffering from any kind of phobias. 5. Panic disorder. Panic attacks have been a topic of research and concern for many years. According to DSM-3, panic disorder was defined as a part of anxiety disorders but differed from other anxiety disorders in only one way, that is, the presence of panic attacks. Panic attacks are referred to as sudden attacks or episodes of anxiety in full force accompanied by fear of losing one's mind, going crazy or dying. The person suffering from a panic attack experiences physical symptoms including palpitation, high blood pressure, choking, shortness of breath, sweating, dizziness and sometimes nausea. The panic attacks are experienced at different levels by different people, that is, some people might experience 5 of the physical symptoms mentioned above, whereas some might experience only 2 symptoms, but both may be experiencing panic attacks. Many years later, DSM-IV categorized 3 different types of panic attacks. Situationally bound attacks, panic attacks which take place in the presence of a particular object or situation, situationally predisposed attacks, panic attacks which take place only in the presence of some situations, not all, and unexpected or spontaneous attacks. Panic attacks in these cases occur at any point randomly or out of the blue. Another characteristic of panic attacks is that they occur or take place in all anxiety disorders and are not only bound to occur in panic disorder. Epidemiology of panic attacks is as follows. Panic disorder attacks are a prevalent and chronic condition. The lifetime prevalence is estimated to be 1-4%, APA, 2000. Researchers have found that women have twice the chance to acquire this disorder than men. A median of 24 years has been found to be the approximate age for this disorder to be acquired. Etiology. Biological factors. Researchers say that there is genetic component in acquiring this disorder. Patients who suffer from this disorder have higher chances of experiencing a panic attack on inhaling carbon dioxide than patients who have other anxiety disorders. Behavioral factors. Behaviorists believe that like all other anxiety disorders, even panic attack can be a result of classical conditioning and an association of unconditional and conditional stimuli. Psychology paper number 15, Clinical Psychology. Cognitive factors. Some cognitive factors that contribute to panic attacks are predictability, controllability, and expectancies. Treatment. Cognitive behavioral interventions. The 3 steps taken from Clark's model are used for the treatment of panic attacks. Relaxation, breathing and body relaxation. Cognitive procedures, instructing oneself to relax in threatful situations, and behavioral procedures. Here the person is made to realize that if the person does not react, the situation will pass and not harm him or not occur also. Pharmacological treatment. Panic disorders have been treated effectively with the help of benzodiazepines and SSRIs. Combination intervention. Researchers have also found that combining short-term dosage of benzodiazepines and long-term sessions of cognitive behavioral interventions have been very effective in improving the condition of patients suffering with panic disorders. 7. Summary. Anxiety, as we all know, is a feeling of distress and uneasiness experienced when one comes across a threatful situation or a feared stimulus. Anxiety can be of 2 types, trait anxiety and state anxiety. There are several anxiety disorders: generalized disorder, obsessive-compulsive disorder, specific phobias, social phobias, panic attacks or disorder. GAD is an anxiety disorder where the person experiences free-floating anxiety without any specific stimulus. The person keeps worrying all the time. Phobias are of 2 types, specific and social phobias. They differ based on the type of stimuli the person fears. OCD is another commonly found disorder. This involves obsessions which elicit anxiety, and to avoid the anxiety or feeling of fear and guilt sometimes, the compulsions are performed overt or covert. Panic disorder or attacks is another anxiety disorder where the person panics either on seeing or remembering something and sometimes just out of the blue. The disorders mentioned above have several causes and the treatment for each disorder have also been mentioned above. The commonly used treatments are pharmacological treatments, cognitive behavioral and cognitive interventions, and sometimes even psychoanalytic therapy.